self-introduce.
קופת חולים כללית.
Hi, so it's a pleasure to be here. Thank you, Dan, for inviting me, and thank you all for having me in this talk now. What I will try to do in the coming half an hour would be to really briefly try to go up a few floors higher to 10,000 feet above the IBD domain, try to take a look at the broader aspects of chronic illnesses, about data-driven policy. As you will see, I come from Clalit. I have two roles there. I direct the Health Policy Planning Department in the Chief Physician's Office, where we do strategic planning, and the Clalit Research Institute that I'll describe in further extent as we go along. So we've seen the issue of the questions whether or not we have an increase or not. Do we have an increase in chronic, in different types of chronic diseases mentioned today, mainly IBD, but the problem is far beyond the specific issue of the gastrointestinal arena. Now, as you can see here, we're moving into an era where multimorbidity, chronic multimorbidity is becoming the norm. If there's anyone in this room that's above the age of 45, then you might be interested to know that over 50% of the people above the age of 45, at least within Clalit, are multimorbid, which means they have more than one chronic illness. And when you talk about over the age of 65, then it's 3 out of 4. So the question, if you don't know that you are multimorbid, two options: either you're in the, as my children say, the smaller half, or that you are, you have not bothered checking properly. Yes. Or maybe that you're not in Clalit. Yes, which also, by the way, is a risk factor for that. Yes, I agree. So as we look at the data, and if you look at the literature in the last few years, you'll see that indeed the most common chronic disease that we have today is actually a disease called multimorbidity. That's the most common chronic disease. Now, rates are going just increasing as far as our data shows. And you can see that there's a classic Pareto law here that a small percentage of the population takes account of the vast majority of the resources. And if you'll take a look again, just to show you a little more data, just to understand, when we talk about the fairly healthy age of 45 to 64, when you take the patients that you see in this hospital, you probably see patients with an average of 4 different chronic diseases. And I'm talking about the young people that you see. When you talk about the older people, we're going far higher. If we take an average patient in Clalit with a disease called chronic heart failure, CHF, then this patient has, on average, or in median in this case, 6 other different illnesses. So there's no real IBD patient or CHF patient. It's a complex array of chronic illnesses that we have to take care of at once. And this is something that, especially when you are in a specialty, in a subspecialty, you tend to see the whole in the patient rather than the other option. And here you can see that the problem really goes beyond just one domain. So rapidly aging population is another issue that we are now withstanding. You probably know that Israel is a young country, but what I'm not sure that you are aware of is that we are the country that is most rapidly aging in the Western world in terms of the aging rate. So we will see more and more of those chronic illnesses as we go in the coming 2 years. We're going to see an increase of 40% in the prevalence, or in the population percentage of the over 65-year-olds. So you can understand what that will do to the statistics I've shown before. So what's the problem about treating multimorbidity? There are several issues that we need to take into account. It's all the challenges that you know in treating chronic illness, and I will not go into the chronic disease models and the classical theories, but you need to take into account all of those problems with chronic illness and then add some synergies. Disease-disease synergies, drug-drug interactions. Some of these patients take 15, 18 different drugs. This is not unusual for a patient with 5 chronic illnesses. Multiple providers need to start talking to each other, which is a big issue and a big problem. In the United States, for instance, the patients who have 5 chronic diseases see 15 different providers every year, which don't talk to each other usually. So how do you make them try to create a reasonable care plan for this patient? Now, you can probably, those of you who have tried to take antibiotics for a week, how many have succeeded in completing the task of taking a single antibiotic for 1 week? Many of us fail. Now think about the patient who needs to take 18 different drugs in different regimens across the day, with morning, evening, forgetfulness, costs, a lot of burdens on the patient, on the families. And just think about, for instance, about diet. Okay, so what can the patient with 5 chronic illnesses eat? Because of the CHF, he can't eat salt. Because of the chronic renal disease, he can't have protein. Because of his diabetes, he can't have sugar. So what is he left with? So if you want to follow the guidelines, you can't basically live. And finally, there's no evidence-based medicine. If you guys think that we are doing evidence-based medicine, you're wrong. In most of the treatments that we give to our patients that we see every day, there's no single manuscript that has shown how to treat a chronic heart failure with 5 chronic other diseases. But that's the patients that we see. There's only about 5% of our patients with just CHF. Most of them have other illnesses. And there's no data, and there's no literature. And the literature is very biased towards very specific subgroups of the population, unrepresentative of this population. So what we actually do today is faith-based medicine. Okay, we have faith in what we read in the general manuscripts that we read and the guidelines that we have, but they have not much to do with the population that we treat. And we need real-life data to know how to treat them well. So this all brings a lot of burden and a lot of challenges to the teams that treat this population. And what we generally do as a health system is to tell our frontline staff, basically everybody sitting in this room, to do more. Because there's fewer resources, and because there's a lot more patients to see, so you need to work harder because you don't work hard enough. So we keep on telling them to do more and more and more. But at some point, this cannot continue and this will break. Because basically, at the end of the road, we are now one of the most efficient health systems in the world. We do much more with much less resources. We have the smallest amount of nurses per capita in any other Western world. The number of beds, I don't need to tell you guys, the number of beds that we have is probably the lowest one in the whole Western world besides Mexico. And the number of physicians is currently okay, but it's going to plummet down in the coming few years, so we'll become, in that aspect as well, a third world country. So this is where we're standing, and we're taking all of those constraints and we're trying to tell our staff that is working very hard to do more and more because there are more and more chronically ill patients with more complex diseases. That cannot stand. In terms of costs, same approach, basically. The cost of the multimorbid patient is several times higher than those of the average patients that we see that are younger and healthier. And you've mentioned before Clalit as an example. Yeah, you shouldn't go to Clalit because, yes, indeed, we see more complex patients. We have an overrepresentation of the elderly population, an overrepresentation of the underprivileged population that is multimorbid. And the meaning of that to all of our costs is considerable. So, where are we now? We are now understanding that we cannot keep on doing the same thing that we've done always and try to deal with this because this will break. And our system is basically broken. When we try to treat chronic illness right now, the way the system is built, it was built for the peasant in the field that fell down and broke his arm. And therefore, you have a system that's built on the patient that have pain or discomfort, going to his general practitioner, asking for care, and then being fixed and sent back. This does not work for chronic illness. So this working silo that we have today, that the hospitals and the community do not speak well enough, that the data between them is not well enough correlated, that is not seamlessly available on both sides, that's a very big issue. We tend to give equal treatment. Equal treatment sounds fair, isn't it? It's good. Everybody gets the same. Well, that's the most unequitable type of care that we can give. Because what we should do is give the patients according to their needs and not giving the same kind of treatment and the same access for everyone regardless of their needs, which is, in the best case, this is what happens. We need to change the whole thought from a therapeutic approach to a preventive approach. And I will show a few examples of how we are trying to tackle that. So this paradigm also has to change. We're doing reactive care. If you have pain, you go to your physician. If you don't have pain, stay home. That does not work in an era of chronic illness. You cannot be reactive. Anybody knows this? Probably not in this institution. But generally speaking, we're still in a highly paternalistic working environment in the way we treat our patients. And the patients, the acknowledged patients in the internet era, want to be much more involved. And generally speaking, for chronic illness, that's the only way, if you want to have adherence and persistence, is by having the patient take part in his care. And finally, we're doing things that have no practical utility. And we are giving care that brings no benefit and no value to the patient. And we do it because our ancestors did that and because that's the way we learned when we were taught. So we keep on doing the same practices when much of this is faith-based rather than evidence-based. So if we want to be able to adjust to a multi-morbid era, we need to change. And we need to change all of this. So we in Clalit have put forward a large, a long-term plan about 4 years ago to try to change all of this and try to move from the left-hand side to the right-hand side over here and try to do things a little better. And we think that the key to make it happen, to do this very difficult paradigm shift, is to use data. It's all about the data. And if you will do wise use of data, you can change. And if you will not, you cannot adapt your system to fit the current challenges of the current era. So we are fortunate because in Clalit, people have been smart enough decades ago to go forward, put large investments in IT and have electronic medical records and administrative data systems put in place fairly early in the 80s. And these have constantly improved through the 90s and current recent years especially. And another thing that we are very fortunate to have, and I think by now all of the different HMOs in Israel today have, is an EMR system with a single software that's available in all of the endpoints in the community that pours all that data into a central data warehouse. Within this data, what's unique about Clalit is that we have there both inpatient and outpatient data because Clalit also has a chain of 14 hospitals. So you can have an integrated system approach both to the data and to the care. And that is what we're trying to do. Another good aspect that we have is we already have about 100 chronic disease registries already there for over a decade. So basically what we have, if you sum it all together, is basically decades of full lifespan ID tag geocoded EMR-based data on over 4 million people. And that is an interesting resource if you want to change, transform healthcare. This is a good starting point, but it's just a starting point. And there's a long way between this theoretical benefit or resource and into actual meaningful results, insights, and changes in policy. In order to help this transformation take place, a real change in the mindset of the organization has taken place about 3 years ago when the Clalit Research Institute was established in March 2010. And it was really a change in the organizational mindset. People who know Clalit know that those changes take a lot of time to happen and happen very gradually. It's a big ship. It moves slowly. But when it moves, there's a lot of power in there. And the mandate of this organization is to take data, turn it into insights, and then take those insights and turn them into policy, into care models. And the beautiful chart that you've shown before of a learning system, this is the same approach that we're trying to take, to go from research into policy, into care models, into actual interventions, do assessment, understand where we are, do a learning system approach, go back to the bench or to the population data and redesign the system accordingly. And you have 3 examples of how this can be done in real-life outcome research, in data-driven care models design, and in new measures for patient-centered care. And I'll try to give a few examples to each one of those. I'd like to acknowledge Dr. Moshe Choshen and Dr. Becca Feldman sitting here, which are the 2 directors of the key parts of the Institute, both on biostatistics and on epidemiology and research. And we are very fortunate to have in this team, in this Clalit Research Institute, a large team by now of really epidemiological statisticians, algorithmic experts, IT experts, clinicians. So this multidisciplinary group is really able to do this very complex process of turning this data into insights. And the examples that I give are all their work. So I don't think we'll have enough time to touch upon too many of these examples that I thought I'd mention today. We'll see how that goes. I'll try to give a few examples of how we're trying to transform care, chronic disease care, to more equitable. One example, perhaps, on coordinated care, and we'll see if we'll get to preventive and proactive as we go along. So the first case study that we'll try to touch upon very briefly would be about integrated care and how data can help us give better integrated care across the different silos of care. So the topic I'll talk about today is called readmissions. I think anybody who works in a hospital in the last few years have by now seen this concept, has been talking about it. It has been an issue not only in Israel, but in other places around the world. It's become a priority, and we'll soon understand why. The first thing I'd like to say is that readmission is not a bad thing. The people tend to think of readmissions as a block of malpractice, bad care, anything of that sort, which is, of course, couldn't be further than the truth. In many aspects, readmissions are part of medical care. In a very good chunk of the cases, readmissions are necessary, are important, and are inevitable. But a significant proportion of readmissions can be prevented and is not needed, as in is actually associated with bad outcomes. So if you have high readmission rates, it's a good indicator of unintegrated care. So if you see differences across your system between subsegments, then you can say that there it's a very good indicator and you should use it. Data from around the world, in this case it's data from UK, shows that the rate of readmissions is going up, basically. So we see more and more patients coming back to the hospital within 30 days after they completed their care. We have data that is showing, at least in Clalit, that patients that undergo readmissions are turning sicker. The readmissions are longer, the rate of complications is higher, the rate of mortality is higher. Readmission is bad for you. So as much as you can avoid it, it is something that should be avoided. So if I just told you that we have a very efficient system in Israel, which means that it's starving. Basically, health systems in Israel are starving, and we're trying to do much more with much less. And the key example is that we have one of the shortest length of stay in hospitals anywhere. So it's 4 days on average. 90 people per bed per year. It's a warm bed approach. As soon as the bed is becoming clear, somebody else takes it. So if you'd have to guess where we are standing as compared to the rest of the world in terms of readmission rates before we started our intervention, what would you have guessed? Would our readmission rates be higher, be same, or be lower? Taking into account that our length of stay is very short. Higher. That was our preliminary assumption as well. So what we've done, we tried to compare ourselves to the rest of the world, and it was a really big challenge. And this work, a lot of work on readmissions is work we've done with Dr. Efrat Shadmi from the Haifa University, a very good collaboration happening there. And we try to compare it with three systems that each one defines readmissions differently. We'll talk a lot about definitions today. It's all about definitions. So just a single simple word that's called readmission. So how do you define readmission? 7 days, 30 days. Urgent admissions, all admissions. All ages, 65 plus. Internal medicine or surgical as well? Do you include the emergency units or not? So with just one word, you can understand how the Babylon concept can come into play. So each one of these defined it completely different. We took their definitions, adopted it, and then made a comparison. To cut a long story short, we're doing better to start with. Despite our short length of stay, we have lower rates of readmissions, and that's very interesting, and it's something that shows the strength of an integrated care system when the hospitals and the community can work well together. So this we want to improve. And our Ministry of Health have decided that we will decrease our rates by how much? 10% in the first year and 20% in the next year, which has not been done anywhere across the globe. This is completely detached from reality, but it's a good kind of horizon to look at. So how do we do this? How do we actually reduce readmissions? So we had a very, there was a multi-pronged approach that we've taken, both at continuity of data, care transition. We put nurses in each one of the hospitals trying to improve the care of the patients at high risk, and to create a contact in which as soon as the patient gets out of the hospital, he will get a call from his community clinic to ask him how he's doing, whether he has his medication, whether he has pain, and what he needs, and whether or not he needs a team to come back to his home or bring him into the clinic in order to take care of him. So I don't care if this reduces readmissions, this is good care. This is the kind of care I'd like to get, and I'd like my family to get. So whatever happens to readmission, this is a good thing that should happen. So one of the key concepts that we're working when we do data-driven care in chronic illnesses is we're trying to do targeted care. We're trying to do personalized care. We're trying to have a more smarter approach. But there's a problem with predicting readmissions. It's just really difficult. And you know, when they say in a very polite English, a complex endeavor, what they mean is good luck. Will not happen. So basically, again, because of the lack of time, I would have gone and would have in a lot of detail on how we do predictive modeling in the Institute. And we have by now have a good track record of creating quite a few of these predictive modeling approaches to care and care models that are based on predictions. We have taken a large set of data, different types of data, and have been able to create a predictive score that's able to identify at the point of admission what is the likelihood of a patient coming back 30 days when he will be discharged, without introducing the data upon his admission into the formula. So, and this was, I think, the first of its kind out there. I hope we'll finally find the time to actually write it up and publish it in the coming few weeks. But this is a model that works very well, and it has higher ROC curves than what we've seen in the literature to date. So this is working. But what we're trying to do is not do nice academia or nice papers. We're trying to change care, to transform care. So how does this go into practice? So this goes into practice in the sense that nowadays, every morning, when every nurse in a Clalit clinic opens her computer, she sees a list of all of the patients that were discharged in the last few days. And those lists is not random. She sees them according to a rank, according to the risk scores that I've just shown. It's already in the data systems. It's already going back to the clinics. It's feeding into the decision process of the nurses. They are calling them according to that. They are using an embedded questionnaire within their system to approach the patient, see if he takes his medication, if he has all the medication, if he knows what to do in time of emergency, and make a decision process whether to send the team over, to bring him over. All of that being done. Add upon that, in all of the Clalit hospitals, every nurse receives every morning in the internal medicine wards this list of the patients that were admitted in the last few days. So she can give a differential treatment to the patients according to their risk. And what this does, just so you understand the power of an integrated care system, once we introduce this into play on the third quarter, we finished the research, basically, and creating the models on the second quarter of 2012. Within 3 months, we had a data system all across the organization. We had a decrease. Look at the decrease in the patients who are not approached by their GP. We have started off with a very good percentage. Only 35% of our patients did not get a contact with their general practice clinic within a week. And now, just 1 year into the intervention, we are reaching below 15%. So this is, in some of our districts, fewer than 10% of the patients do not get approached. So this is, I think, quite a remarkable impact of how data can transform care fairly rapidly. We also see a decline of, by now, almost 5% in readmissions. So this is working very nicely. Time is running quickly. Basically, it's 20...
discussion time, so
yeah, so according to my accounting, I have 7.5 more minutes, but because I started late. But let's do this quick. I'll run quickly. Just to give a few more aspects of equity of care. Probably people here know that just improving quality does not increase equity. It's the stronger subpopulations that absorb your interventions quicker. It's the poor people that are last to improve in their quality improvement. And data, just measuring quality is not enough. And again, just the same theme, everybody around the world tried to reduce equity. Basically, everyone failed miserably. Just very few programs out there that have been able to achieve a real reduction in disparities and increase in equity. We've decided in a public health approach that is very unlike an HMO, basically, to take reducing disparity as a strategic goal. We've done it already in 2008, years before Ministry of Health have started dealing with those issues and putting incentives on them, et cetera, et cetera. And again, because of the lack of time, I will not be able to go and explain to you how did a very smart use of our quality indicators to create composite scores that are directed at health disparities, identify clinics for intervention, identify 400,000 people that we wanted to take our biggest efforts on, which were the lowest achieving 10% of our population. We had a whole system and a whole strategy behind this and how this will work. And to cut a very long story, very short, I think this graph helps understand what we've done in just a few years. This graph describes our preventive medicine measures, our classic measures that everybody use most of it by now. Most of the HMOs use the same measures. You can see what happened to them between the three socioeconomical status groups in Clalit over until 2010. Nowadays, I can tell you there are no disparities in the preventive measures in Clalit by now. When you talk about the most difficult to change measures, the 7 most difficult to change measures that we put in place, we managed to reduce 60% of the differences. And when we stopped the intervention in 2012 to see what happens if we do laissez-faire, whether or not they decrease or not, we see that all of our achievements were maintained, and actually both of the groups actually kept on improving. So we have shown, and this was actually been acknowledged by the OECD in their reviews of the Israeli healthcare system. And maybe I would just mention that when we try to look by now on myocardial infarctions, we see that we are starting to achieve a reduction in the disparities in some of the outcome measures as well, not only of the process measures. So I thought that at this point I would need to leap forward, so I'm leaping forward. This is the traditional work that we've been doing in monitoring non-communicable diseases. Surveys, repeated surveys. This is not the way of the future. The future is on using various types of data, and EMRs, etc., are just the beginning. I'm doing some work with the WHO right now. We're looking at some new ways of monitoring NCDs in Europe, and there's a platform that will be put into play, I think, in the coming years, using additional types of data, social media, mobile data, really innovative stuff that is currently taking place. And so this is some beautiful work that you'll hear more, I think, in the coming few years. There's an ongoing work in progress. But we will have a chance today to hear about all the inadequacies, okay? There are many problems with using this data. The silent patients that are unrecorded, problem with the harmonization of data, which sometimes make our efforts to unite databases very challenging. Biases in providers, in access, in demographics. If we had the time, we could have talked about it more. But to summarize, the only way to achieve a real transformation in our healthcare system is through data and through judicious use of data. We can use data to get new insights and to change the system, to put in new models, to monitor trends, to identify priorities, to do risk stratification, to target care to the patients according to their needs. All of these sounds like a futuristic approach, but it's not. These are things we do today in Clalit on an everyday basis, by now on the desktops of every nurse and every physician, both in the hospital and the community. As the years will go by in the coming years, we'll do more and more of these, and some of the work that we are trying to initiate in these months today, also in IBD, might be another very important track in that overall direction. So there are a lot of requisites, there are a lot of things still to be achieved, but to finalize, I will just say that it's not enough to do your best. You should actually know what to do, and then you need to do your best. Thank you very much. And type of questions.
Fascinating talk. So going back to IBD, from what I understand is for organizations that look at preventive medicine and Schedule A, I mean, it's very easy to take IBD patients and do the same thing, like pop-up windows. Did you see the eye doctor in the last 3 years? Did you do levels of Imuran? Did you do CRP before you send someone to referral to, I don't know, to endoscopies or et cetera, et cetera? From my understanding is that the organizations are not very thrilled to go that path, because this is money that goes out now from their budget to questionable saving in the future. And in the end of the day, it's all a balance of money. And this is understandable. So how much is really Clalit of the HMOs are really receptive to the ideas of doing better medicine, of what we think should be a better medicine?
Okay, so you touched upon two really important points. Better medicine, we think, which in some points those two are not necessarily go hand in hand in the what the organization views. And again, we go back to the question of when do you have enough data to show that something that you do is actually useful. It's not necessarily every professional society sees their practices as the most important things that need to happen, and has sometimes a tendency to push forward on procedures and intensive approaches that in public health approaches sometimes not necessarily have been proven to be with added benefit in overall outcomes, overall survival, overall care. You have mentioned in the beginning of your talks, one of you guys mentioned that we should start measuring what the patient benefits from all of everything that we do, which in too many aspects we don't. We try to see surgery as one of the outcomes, but how about some patient-reported outcomes and what they actually benefit? We look at our system as a very complex machine that in one side you put money and in the other side you get health. We don't try to put in money to get money. This is not a cost-saving kind of an approach. If we can prove that any approach is something that adds health and adds benefit, it is something that would be happily taken by any of the organizations that I'm involved in. But there's a question of asking whether or not the guidelines are indeed important. Every piece of thing in the guideline has the evidence for the outcome and the benefit and the end game benefit, not some kind of ameliorating an intermediary data measure that you have, whether or not it adds value to the patient. And if it does, I'm sure it will be inserted. In terms of the measurements, Clarit is now moving very deeply into specialty care, quality measures, and everything that can be shown to be really associated with benefit to the patient can actually become checklists, guidelines, automated alerts, and all of that. We are certainly can prescribe to that if we know that it adds really benefit. Yes.
You're more able to look specifically at the factors and at the results, which is why we should put even more effort into such diseases.
I fully agree, and I want to say more. I think that in the past, the identification of new drugs and new treatment modalities were based on serendipity, and on the likelihood of someone just bumping into the right drug. This is changing rapidly, and in silica and these types of approaches to identify populations that can benefit more from the treatments are at higher risk for developing either the disease or its complications, and all of the other aspects that were mentioned are really the future way to go. I do agree that it can be done in IBD as being a very sole disease usually that you can really focus on, and in the sole attention of both the patient and his family in many aspects. I do agree. I think we are just in the beginning of a very interesting way forward. We can identify new modalities, new ways of identifying the patients, and new ways of treating them. So I do agree there's a lot of potential there. Eric.
So just, I guess, a question and a word of caution about the quality indicators that you're using and that you may develop later, especially when it comes to IBD. I think the concern that we've started having, at least in North America, in the pediatric realm, is that the quality indicators for asthma, the quality indicators for IBD, the quality indicators that have been published that people are putting into quality improvement programs are based primarily on RAND methods, so really expert opinion and some evaluation of what's available in the literature, and don't necessarily correlate with the outcomes of the patient later on, whether it's patient-reported outcomes or clinical outcomes. And I think in IBD we're starting to see that with improved care now, which is an extremely expensive method of tracking quality indicators and tracking what people are doing and feeding back to people what they're not doing well. So you already have that, so it would be less expensive for you through the electronic health record. But and the most recent publication has demonstrated but only in patients with pretty much mild disease to begin with. So I'm sort of just, it's a roundabout way of saying be cautious, that I think I agree with what you said, that we really, really, really need to measure adherence, but also measure outcomes, and find out which are the best quality indicators that correlate with outcomes, and not jump to things like pay for performance before we have validated the quality indicators to begin with.
I could not agree more. I alluded to that, but maybe I didn't say it clearly enough, that there are issues with evidence and with value in some of the current guidelines, and we will not turn any of those guidelines into any quality measures or automated decision support for any piece of information that we're not absolutely sure that adds value to the patient on the overall outcomes, and not in any surrogate measure or any expert opinion. So I think that was now made very clear.